CTO stands for chronic total occlusion, and that means that whereas most of the arteries that we treat with angioplasty are open, even if they're narrowed to 99% of the diameter of the artery, we can still see the blood flowing from top to bottom, and therefore you can see where the wire needs to go. And usually with modern technology, once we can get a wire down the artery, then it's possible to then pass a small balloon, dilate it up and so on, and then lead to being able to put in a stent. However, if the artery is completely blocked, and if it's been blocked for more than 3 months, then we call that chronic, as in blocked for a long time, total occlusion. And that is that's an aspect of angioplasty which, until a relatively short time ago, just a few years ago, was something that created real problems for interventionists, because not being able to see exactly how the artery tracks, and because there's a blockage, you can see where the blood flows at the top, you can see where it comes from the bottom, but there's a gap, and these gaps are usually of the order 2, 3, 4, 5 centimetres in length, so they're relatively long. And so the principles of trying to establish flow in what we call a CTO have now been justified from the literature. We know that patients that only have, say, a single artery which is blocked actually do better by having that opened. We know that it can cause a major improvement in terms of relief of symptoms, but we also know that prognostically it's hard to justify referring those patients for bypass grafting when they may only have one artery which is affected. And so a number of techniques have been developed which actually enable us to not simply pass a wire where we can see where we're going, but to actually bridge this occlusion. And simplistically, that they're divided into 3. One is to use specialized wires that try to work their way through the actual occlusion. If the occlusion is relatively short, that's usually possible. If the occlusion is long, then that's almost impossible. And then we have special balloons which enable us to actually track down, not through the blockage itself, but actually in the wall of the artery. So effectively we bypass the actual blockage of the inside of the artery, go down the wall, and then once we've done that, we can dilate up the wall of the artery and then put stents in there, and we know that that has good long-term benefits. And in some situations, we can also actually, instead of coming from top to bottom, we actually can go down the coronary artery on the other side of the circulation, use some little channels that the body generally opens up to communicate between arteries that are completely occluded, and actually pass a wire down effectively the wrong artery, back the way up through the blocked artery, out through the patient, and then we use that as a track. And then once we've done that, we can then dilate up and put in stents and then re-establish flow in the artery that's blocked. So these are relatively new techniques. They are a relatively small number of interventionists have acquired the skills to be able to use them, but they're a very, very gratifying group of patients to treat, and we're seeing more and more patients that are being managed with CTO PCI rather than being referred for surgery, especially if they've had previous surgery, because most patients would prefer to avoid redo bypass grafting surgery.